It's Friday, the 14th of February, and love is going to have to wait because it's time for the Hot Topics podcast. Welcome to the Hot Topics podcast from NB Medical. Neal Tucker here as usual. And in this edition, we've got 3 new pieces of research that we're going to take a look at that are relevant to us in general practice. But before we get down to the medicine, just to highlight that we've currently got an NB Plus offer running. This is a Valentine's offer until the 17th of February. That's this coming Monday, a 25% discount, making it just over £300 for the year. And you can come on all of our live webinars for all of our different courses. We've got more than a dozen of them now. You can access them all on demand, all of the online books and loads more besides. I'm not going to go so far as to say that you should buy this as a present for your loved one, because I think that would go down about as well as the time I bought my wife a bread maker for her birthday. But maybe just treat yourself. And we've got a lot of good stuff coming up. So we've just put the finishing touches to our new Hot Topics course, the Spring 2025. Loads of exciting new topics that we've got to discuss. And the first date we're going to be doing that is on the 8th of March. I think we're following it up on the 14th of March after that. And we've got loads more courses coming up in the near future. So on the 7th of March, that's a Friday, we've got our abnormal blood results course. A week after that, we've got our diabetes course, our urgent care course. We've also got our advanced clinical practice update course coming out on the 15th of March. So if you are an advanced nurse practitioner, paramedic, pharmacist, physio, physician associate, if you want to stay on top of your CPD and continue learning in your role, then this is the course for you. So do check that out as well. Okay, let's get on with the medicine, and 3 great papers today. The first is in the BMJ, a paper looking at arterial thrombosis risk linked with hormonal contraceptive use. Second is a paper in the BJGP, a network meta-analysis exploring how effective safety netting advice is in general practice. And third, we got a paper in JAMA Internal Medicine, which is a systematic review and network meta-analysis of antiviral medications for non-severe flu. That particularly piqued my interest because I'm pretty sure I had flu last week. Okay, on with the medicine. First up, we've got this BMJ paper, and the title of which is Stroke and MI with Contemporary Hormone Contraception. So they're looking at arterial thrombotic complications linked with hormone contraceptive use. Now, it doesn't sound like this is a particularly new area. We've got research and data existing here. But as the paper points out, this observational data and existing meta-analysis, the findings have been a bit inconsistent, and ultimately they're often from quite outdated studies. Things have moved on. We've got different progestogens that might be used. We've got different modes of administration. So you might have a combined contraceptive ring or patch, not just a tablet. This paper then is based on a prospective cohort study taken in Denmark. So in Denmark, they've got really good online searchable records for contraceptive use and a range of other health conditions as well. So the authors of the paper were able to go and look at their target audience, in this case, women aged 15 to 49, excluding those with important comorbidities such as a gynecological history, use of hormone therapy or previous thrombosis, leaving them with around 2 million women to examine, 22 million person years to analyse, and around a quarter of that population used hormonal contraception during the follow-up of the study. The primary outcome was first-time diagnosis of ischemic stroke, or MI. Let's take a look at the ischemic stroke data first. So if you were a non-user of hormonal contraceptives, the background rate of stroke was 18 per 100,000 person years. That went up to 39 for combined oral contraception, 33 for progestin-only pills, and 23 for an IUS coil, although it's worth noting that that 23 is not statistically significantly different than the background rate of stroke. Rates of myocardial infarction were lower, so the background rate was 8 per 100,000 person years, 18 for combined contraception, 13 for progestogen-only pills, and 11 for the IUS. To keep things really simple, essentially if you took combined oral contraception, you had double the risk of stroke or MI than those who weren't using hormonal contraception. They then did further analysis on the specific types of combined contraception that were being used, and again they saw differences. So for the combined vaginal ring, certainly no safer than using combined oral contraception. In fact, perhaps slightly riskier. The incident rate ratio was 2.4 times for stroke and 3.8 times for MI. Having said that, the confidence intervals for those figures are much wider, probably just representing the fact that there's going to be lower use of vaginal rings, so we've got a smaller data set compared with oral therapies. As a result, our certainty about exactly where within that range the true answer lies isn't as good. So I think we have to take those answers with a little bit of a pinch of salt. And that's further backed up by the fact that when they looked at the combined contraceptive patch, so that had an incident rate ratio of 3.4. Remember, we said it was 2, essentially a doubling of the risk for the combined group of combined hormonal contraceptives, and actually no MI events in the patch group. And that's not showing that the patch must therefore be safer from an MI perspective. That's just really showing the challenges when you've got a small data set and a rare complication that you're trying to examine of really being able to identify what the true risk is. So what can we take away from this study? Well, firstly, good news really, the arterial thrombosis risk with any of these options is really pretty low. It's a little bit higher with combined contraceptive hormone therapies versus progestogen only versus the Mirena coil or other IUSs. But ultimately, a risk increase of 20 per 100,000 person years or 1 per 5,000 person years is really pretty small. And as ever, you weigh that up against the potential risks of pregnancy if you don't want to be pregnant. And of course, then the risks come out much higher than that. What I think this research does serve as is a reminder for us that we should be thinking a bit about arterial risk and arterial risk factors, as well as risk factors for venous thromboembolism as well. Luckily, I guess they're kind of all rolled up into one. This is increasingly important as we're starting to see more and more cardiovascular events in younger people, realistically driven by the increasing rates of obesity in our population. 1/3 of children leaving primary school now has obesity, and that has dramatic impacts on their cardiometabolic health at a much younger age than we traditionally thought. And in fact, I was just reading the BBC News this morning, trying to keep up to date with current affairs, and I see that there's a report on there from Clive Myrie. He's a war correspondent, and they've got him spending 24 hours in the Royal Free in London. You do get the impression that it's a little bit like a war zone. And one of the issues that the staff were highlighting was that they were seeing more heart attacks and strokes in people in their 30s than they have done in the past. None of this is to say that we should be withholding contraception from young women, but what this shows us is that there are potentially lower risk options. And if we think someone, when we're doing our individual risk assessment of this person who's come to see us about their contraceptive options, this data helps us understand what those low risk options are and therefore inform our patients more effectively. Okay, next up, we've got this BJGP paper, Effectiveness of Safety Netting Approaches for Acutely Ill Children, a network meta-analysis. I was presenting our urgent care course earlier this week, and we talk about the latest NICE guidelines on bacterial meningitis and meningococcal disease in that. And I was just reflecting on a case I had years ago when I was pretty newly qualified, and essentially in an under 1-year-old, I missed meningitis. And the saving grace was when the child deteriorated, because of that safety netting, advised the parents knew exactly what to do and rapidly got the child reassessed. And thankfully, the outcome was okay in the end. What's a bit surprising about safety netting, given the fact that we all do it so often and it's such an important part of good healthcare, is that there's significant heterogeneity in how we approach this. So I suspect for most of us, most of the time, it's going to be just oral safety netting. We're just verbally giving people some information. But It could be paper, so they could have a printout and actually physically give it to someone. It could be web-based, so you send them a link and they can have a look at a website with that information on. And in this paper, they also talk about video safety netting information and even web-based modular safety netting. That last one took me a little bit by surprise, because the last thing that I want to do if one of my kids is sick is be given homework. In fact, they identified 20 different interventions out of 30 different studies, 17 of which were performed in paediatric A&E, 13 of which were in primary care, not necessarily UK based, but all high income countries. The outcomes of interest they were examining were antibiotic prescribing, antibiotic consumption, return visits, parental knowledge, and parental satisfaction. And while all of those have merit, I'm still sometimes surprised by their onus actually in the paper is about antibiotic prescribing. Whereas for me, when I'm thinking about safety netting, I'm thinking about ultimate safety of that kid and what's going to prevent them dying. Do they know what to look out for, where they should go, how fast they should get there if something goes wrong? Anyway, I hope that information is captured in their phrase return visits. So on to the results. And I think the most telling sentence in this whole paper is this. The authors said, the certainty of evidence for all primary outcomes was low to very low. What that means is we have to take absolutely everything with a big pinch of salt. The data just isn't that good. And we all know if you put weak data into a meta-analysis, you're going to get a weak outcome. I think probably the key finding from this assessment was that compared with usual care, paper safety netting advice, probably in combination with oral safety netting advice, seems to come out top. So it's better at reducing antibiotic use, it's better at reducing the need for return visits. Although surprisingly, it doesn't seem to improve parental knowledge, whereas video safety netting advice, read-only websites, oral advice, and web-based safety netting advice does. Meanwhile, video safety netting advice and web-based modules may improve parental satisfaction. Presumably only people who enjoy homework actually agreed to participate in those particular studies. The authors conclude that use of paper safety netting advice is to be encouraged. That, in combination with oral safety netting advice, may be the most effective approach at reducing antibiotics prescribing, and video safety netting advice and online materials can also be of use. I'm a little bit skeptical at exactly how much we can read into any of these findings, but taken on face value, I feel a little bit sad that we're back to the era of printing things out. 15 years ago as a GP trainee, I used to do this quite a lot, but then we got Accurix, and then I just started sending out people web links. And there are some great resources out there. I wonder if you've ever come across the Healthier Together website. So this is safety netting advice on a massive range of conditions, specifically for children. And it was a program that was put together by the NHS, the Royal College of Paediatric and Child Health, specifically in, I think it started in the Isle of Wight and Hampshire and Dorset maybe. I see they now specifically have a Healthier Together West Yorkshire webpage as well. But the vast majority of the information is nationally generic and it's really high quality. I was really impressed with the work that's gone into this. It's definitely something that deserves to be nationally commissioned. I guess what you never know when you send off an Accurix is how many times people actually click on the link and then read the information. But then the same could be true for handing them a piece of paper. Sounds to me like there's another piece of research in there for someone. And finally, our third piece of research published in JAMA Internal Medicine a couple of weeks ago, antiviral medications for treatment of non-severe influenza. So, antivirals for flu then seems to be something that you and I have never really adopted. It's a bit of a surprise because national guidance has been around for years on this. And I was taking a fresh look at this in preparation for this podcast. And I was surprised. Again, I mean, I've looked at this before. I shouldn't be that surprised, but I'm surprised at quite how wide a range of indications there are for antivirals. So if you've got complicated influenza, which means you're effectively going to be hospitalized, or you've got a lower respiratory tract infection linked to the flu, or you've got some kind of CNS involvement, then that's pretty straightforward. That sounds very reasonable that you might give someone in that situation an antiviral on the hope that it's going to help them. But that's pretty unusual. A much more common situation for us is that flu's going to be uncomplicated. So like me last week, you've got days of feeling malaised, feverish, muscle aches, you know the score. I have to say I was feeling pretty smug over the Christmas period. Everyone around me, my kids, my friends' kids, they all seemed to have flu-like illness at the end of December, the start of January, and I seemed to completely escape it. And I thought maybe this year I'd got away with it, and then bam, after a school disco where I was chaperoning, stuck in a school hall for 2 hours with 200 sweaty, screaming individuals, and that was just the parents. Anyway, it seems to me that I'm one of the few individuals that wouldn't be eligible for oseltamivir. So if you are in a higher risk group and within 48 hours of the onset of symptoms, you could be recommended this treatment. And risk factors include things like diabetes, age over 65, a range of chronic conditions, be it neurological, hepatic, renal, pulmonary, or cardiac, and more besides. And yet, I suspect that lots of us have gone through this flu season seeing loads and loads of patients. I mean, the levels were clearly really high about a month ago, and I feel like they're dropping off now. But I'm going to hazard a guess that almost none of you will have prescribed flu antivirals for almost any of your patients. And I wonder why that is. Is it because the data's been a little bit sketchy over exactly how much benefit they're likely to give? Is it because we know that they're linked with quite high rates of side effects, particularly nausea and vomiting? Well, I wonder if this new systematic review and network meta-analysis will change your mind. So 73 trials with 34,000 participants comparing standard care or placebo against a wide variety of different antiviral drugs. And what did it show? Well, essentially, none of the antivirals had basically any effect on mortality in low or even high risk patients. Specifically, I think they used the phrase little or no effect. And the strength of that data, in contrast to our previous study, the strength of this data was high, so high level of certainty here. The authors showed that all antiviral drugs had little or no effect on hospital admissions for low-risk patients. Perhaps no surprise there, but the same was true for high-risk patients, with the exception of one drug that I'd never heard of before called baloxavir. So baloxavir is licensed in the UK, and just looking it up in the BNF, you give it as a single stat dose and it costs £100 a time. Now, I suppose that might come out as a cost-effective option, but they do suggest that the absolute risk reduction there is, I think, 1.6%. So you might be preventing 16 hospital admissions for every 1,000 people that you treat. I'll let you discuss that amongst yourselves. And of course, then there's always the flip side, which is the adverse events that these drugs cause, and that there was more certainty that they were likely to cause adverse events. So circling back around to our original question, why don't we prescribe more antiviral drugs in flu? Well, I think that this paper pretty much sums up the answer. Antivirals for flu are a load of baloxavir, that is. Okay, thanks so much for joining us on the Hot Topics podcast once again. We will be back in 2 weeks' time with another special edition. This time we are interviewing Dr. Helen Salisbury of BMJ fame. We'll be talking to her about how general practice has changed over the last few decades and where we think it may be changing to in the future. I'll be back with the regular podcast in 4 weeks' time. And between then and now, hopefully I'll see you on our new Hot Topics course. Check out nbmedical.com for more information. Look after yourselves, everyone. See you soon. Bye-bye.